But thank you for having us here. This IC has been a part of All India Ophthalmological Society meetings for the past 13 years, and it's always been rated as one of the top instruction courses. So thank you once again for having us here, and without further ado, let's move on to the first lecture, which is the relevant facial anatomy on cadaver dissection and what to be aware of. It's a very close friend of mine, Dr. Shilpa Taneja Mittal, who will be speaking on this, and Shilpa is a very well-known oculofacial plastic surgeon from Delhi.
So good morning, everyone. So next few minutes, I'll be taking you through relevant facial anatomy on cadaveric dissection. And as we all know that anatomy is the most basic, yet the most relevant and important part before any surgery or any procedure. Why should we learn anatomy well? Obviously for safe and efficacious injections so that we don't go wrong. And to achieve consistent results every time. We should know what we did before, and then only we can judge ourselves and do the thing rightly or in the best possible correct way the next time. So I have divided this presentation for convenience. Will this message troubleshoot sound problems will be there? It's not going, okay. So I have divided it into 3 parts. First part will cover the upper face, second the middle and lower face, and third the vasculature of the face. Starting with the first part, the forehead. We all know the most important muscle is the frontalis muscle, the only elevator of the forehead. It goes from medial to lateral and usually bifurcates into a V-shaped pattern as shown in the picture. Although not in this cadaveric specimen, it is not bifurcated in this specimen. When we need to inject neuromuscular agents, ask the patient to animate to know whether the frontalis is a uniblock or a divided muscle. Next is the corrugator and the procerus, the depressors of the brow. The corrugator, as seen, lies here, and the procerus in the center. When we need to inject into these muscles, we must inject deep into the belly of the muscle. After we have known the elevators and the depressors, we all know the glabella is the most common site of blindness or vision loss after filler injections because of the multiple vessels in this area. So we must always inject very small bolus and in a small fashion. That is why this becomes a danger zone, because the supratrochlear and the supraorbital vessels are there, and we might inadvertently inject fillers and have some complications. Next are the supraorbital nerves, which travel into the center part of the half of the forehead here. If we inject neuromuscular agents here, we might cause some neuromas and pain to the patient. Deep injections into the corrugator muscle here also are sometimes very painful to the patients I've seen in my clinical practice. So the supraorbital nerves and vessels travel here in the center, and we should be cautious while we are injecting the frontalis muscles injection here. The fusion zone between the frontalis muscle and the temporalis fascia and the muscle is important to note. The temporal part of this area starts from the line connecting the lateral canthus to the root of the helix here. Inferiorly, it is bounded by this line, and superiorly by the fusion zone. So this is the temporal area where we need to inject filler sometimes in few patients. Again, we should remember the danger zone. 1 finger breadth above the lateral brow is the superficial temporal artery, and the frontal branch of it lies here. And inadvertent injections into this can lead to complications again. So always aspirate before you inject. As we lift the superficial temporoparietal fascia, here lies the middle jugular vein, which is a big vein. Injections into this vein drains into cavernous sinus. So drainage, the retrograde flow of the embolus again can lead to complications, severe life-threatening ones. So when you're injecting in this temporal area, one must be cautious. Always aspirate before you inject. The safest area when we want to inject in this area is between the skin and superficial temporoparietal fascia, or very deep after aspiration. So after we finish the first part, that is the forehead. So as we can see in the diagram, this area between the skin and the superficial temporoparietal fascia is the safe zone, and deep lies the threatening vessels. We come to the next part, which is the mid-face. The most important structure here lies here, the frontal nerve. It gives branches. The superficial temporal artery is the main thing to remember here again. One finger breadth along with it lies the nerves from the branches of it. The aesthetic contours are formed by the facial fat planes, the superficial ones and the deep ones. There are 21 facial fat compartments. The malar area is the important one, which we must know. It is divided into the inferior, middle and superior, as shown by this video. The inferior, middle and the superior. In females, we usually inject up in the zygomatic arch area, and males, we inject here deep into the malar fat pad, in the malar fat pad compartment. So these are the important fat pads we must always remember. The next important part is the infraorbital nerves and vessels, which lie medially, as we all know, being ophthalmologists. When we need to inject in this area, always inject lateral and massage the filler medially, so that we don't inadvertently damage these important structures here. And also, injecting the fillers medially might accentuate the nasolabial fold, so it is avoided any case. The next important structure to remember here is this vein, which we can see here, the bluish vein, the facial vein branch. It is in the superficial fats. So again, injecting deep here into the deep malar fat pad helps, and obviously aspiration is the key. The important structures to be noted in the perioral area are the 4 major mimetic muscles of the face: the zygomaticus minor and major, and the levator anguli oris, and the depressor anguli oris, and the relationship of DAO and DLI. So these two here we can see are the zygomaticus minor above and the zygomaticus major below. We must remember, when we are injecting for crow's feet here, inadvertent injections into the insertion of these muscles may lead to the ipsilateral frowning of this depression of the smile here, the droop of the angle. So we should be cautious and inject superficially near the lateral canthus. This is the levator anguli oris muscle, and this is the broad fan-shaped muscle here. We can see the depressor anguli oris muscle. Deep to this DAO lies the next important structure, the DLI, depressor labii inferioris. When we need to inject in this area, we must always inject lateral and not medial. Injecting medially can lead to the drooping of the lower lip, difficulty to the patient in eating, swallowing, salivation can happen. So 1 finger breadth lateral to DAO lies the most powerful muscle of the face, the masseter muscle. Injections into the masseter are done for bruxism and for facial symmetry and thinning down the masseter muscle also. And this injection here will show that the masseter muscle is quite deep below the all facial fat pads. And when this syringe is taken out, we can see that around 1 to 1.2 centimeters deep we need to go to inject neuromuscular agents into the masseter muscle. So this is important thing to note. Next thing which we need to see are the vasculature of the face. The most important facial artery, which starts very deep into the face lower down, and as it goes up, it becomes superficial near the ala of the nose. It lies 1 thumb breadth away from the angle of the mouth here, as we can see. and it gives branches at the commissure known as the superior and inferior labial artery. These superior and inferior labial arteries lie at the junction of dry and wet vermilion, and they are usually deep below the orbicularis oris superiorly, and inferiorly they are deep to this muscle, the DLI. So this is the artery which we can see, and this is the DLI. So when we are injecting in this area, inject superficial, not very deep. Don't go below 2 to 3 millimeters for lip injections. Otherwise, again, embolus can be there in the arteries. Here, this artery becomes superficial and lies 1 finger breadth away from the ala of the nose. When we are injecting just beside the nose, we usually go deep and aspirate. That's the reason for it. And plus, we want to embed the filler basically there. As the artery goes up near the nose, it gives various branches. The branches anastomose with the columellar vessels, the dorsal nasal vessels, and the vessels at the radix here. So the most safe part here to inject is the middle part of the nose, which is the safest zone. Otherwise, the embolus can travel in a retrograde fashion. So these were the important structures. So the lowermost part is not a safe zone. The uppermost is not the safe zone. The centermost part is the safest zone, the SMARS area. With this, I would like to finish my presentation. Thank you all for your kind attention.
Thank you, Dr. Shilpa. Like every time I hear Shilpa speaking, I feel that every time she adds so much of newer concepts and like what is new happening. And it's really very nice to listen and also learn from you, Shilpa. So now we have Dr. Adit. I think Adit is one of the most prolific oculoplasty surgeon in India. He had done his fellowship, first fellowship from L.V. Prasad Eye Institute, Hyderabad, and then he went to US for his second fellowship under Dr. Robert Goldberg from UCLA. And Adit is the director of the Mumbai Eye Plastic Surgeries, that is their center. He's a great aesthetic surgeon and also does very good work in thyroid eye disease. Over to you, Adit.
Thank you, Dr. Kasturi, for this introduction. I also have to thank Debraj for running this course successfully for so many years. And it has always been well received. Today, unfortunately, we are post-gala night and everyone was dancing till 3 a.m. So obviously, it's an expected thing that you will have less attendance. But in this course, we usually run from the basics to advanced. So in the end, Debraj will be showing a cocktail of everything. And we will be going step by step, as Shilpa has already made my job easy by describing the anatomy. Now I'll go and touch the very basics of Botox, especially focusing more on the periocular region. We all know that Botox can be used for cosmetic as well as functional regions. And as ophthalmologists, we should be proud of the fact that the inventor of Botox was an ophthalmologist-dermatologist couple who actually injected a person for glabular lines and for blepharospasm and noticed an improvement in the glabular lines, and that's how it got thrown into the cosmetic world. Now, before injecting, we all inject, right? We are all surgeons, so we know how to inject. More than injecting, I believe that for any injectable fillers, be it Botox, it's how you evaluate the patient and how you counsel them and how you know how not to say yes to a patient who is very manipulative or is going to be a problem patient. Before evaluating a patient, you should always know that skin is made of multiple layers, the face is made of multiple layers, and what we are targeting with Botox is just the dynamic lines. So you should not over-promise a patient that Botox is going to work magic. You should know that there are other structures which have to be addressed as well, which Debraj will be discussing in his talk. A lot of ophthalmologists who initiate their practice into Botox always tell me that, I'm not able to convince patients to get Botox done by me. While performing these aesthetic procedures, you have to choose your words with caution. You have to avoid certain words and have to be soft, like how you counsel a LASIK patient for this procedure. Photographic as well as videographic documentation is very, very important because, every patient has a different sort of sign map and you need to customize your treatment for every patient. So before injecting, you need to ask the patient to do all sorts of dynamic movements and see which muscle is more acting than the other and the pattern of the muscles and what kind of injection dosage would be required, which should be customized to each patient. Comfort of the patient is also again very important. So I always advocate to use skin anesthetic cream, which is a mixture of prilocaine and lidocaine. It should be applied copiously on the region that you are going to inject. It should be kept for a minimum duration of around 30 to 45 minutes because it numbs the skin to an extent that the prick can sometimes not be perceived at all. So here you can see we are applying in the eyebrow region the EMLA cream which is available. You can also use an occluder tape if you are in a hurry or the patient is in a hurry, because this occluder tape potentiates the action and penetration of the skin. It is available with the ointment itself. So instead of waiting for 45 minutes, you can perform your procedure maybe in half the time. This occluder tape certainly makes a big difference. Now, muscles have already been described by Shilpa, but what we focus on in the periocular region for Botox is mainly the orbicularis, the frontalis, and the eyebrow depressors muscles, which comprise of the corrugator, the depressor, and the procerus. Now, in the market, there are multiple options available. This is the APAO, so there are multiple options available in the Southeast Asian region as well. And once the patent of Botox was won out 20 years after Allergan had to let go of the patent, there are multiple Botox molecules available in the Indian market as well, which are slightly cheaper than the original molecule and have fairly comparable efficacy. If you use it in your practice, you will come to know more about it. There are broad consensus guidelines which have been given by the PRS in 2004. This was one of the landmark articles where a broad consensus group had given guidelines, and now we have similar guidelines from the Indian group as well. But as a rule, usually you should use non-preservative normal saline because the pain of the injection is less. Concentration can be titrated according to your usage, and the the label says that you should use the Botox for not more than 24 hours after reconstitution, but safely it has been shown that you can use it up to a month if stored properly, and special precautions should be followed while handling. It should be completely aseptic. Now, this is the biggest point that I emphasize on is keeping a track record, especially for the first 2-3 injections. When you inject a patient, you need to know how a patient responds to the injection. So these charts are very easily available by the company wherever you procure your Botox from. These help a lot in your practice in the initial days to titrate the dose, to convince the patient that you are keeping their important records with them and show them that we have injected like this and do you want to change something about it. Consent again is very important from the medico-legal point of view. Now let's come to specific indications. As ophthalmologists, we are very comfortable around the periocular area, but if one indication that you want to begin with initially is the crow's feet, because it's one of the safest sort of areas to inject. Very few things can go wrong in this area. For the crow's feet area, usually we begin with 3 points, the topmost, the middle and the lowermost, which is basically where the rytides are. The muscle that you're targeting in this area is the orbicularis oculi, which is a sphincter-shaped muscle, goes around the eye. And depending on how radiating the crow's feet are, you might have to add more points beyond the 3 points that I spoke about. Now, you have to administer caution while giving Botox in this area. You should not go too beneath, otherwise you will end up injecting the zygomaticus major and the minor muscles and cause a crooked smile. So you should be careful about that. And in the inferior crow's feet, you should not go too close to the orbicularis muscle because sometimes you might end with epiphora. While injecting the crow's feet, also one thing that you can do is you can keep your finger within the orbital rim to help the molecule from not diffusing in the orbit. The usual starting dose for crow's feet is around 12 to 30 units, depending whether it's a male or a female patient, and 2 to 5 injection points can be followed. This is a short video which shows how crow's feet injection is done in a patient. So this is the topmost point. Now, if you are comfortable, you can inject with the needle pointing towards the globe, but as beginners, I would advise that you can inject from the opposite direction where the needle is pointing away from the globe, and you can keep a finger within the orbital rim. Now this is the midpoint which was injected. Now since this patient had more radiating lines and wanted a elevation of the eyebrow as well, additional point is injected in the tail of the eyebrow, and then you see inferiorly just the lower crow's feet is targeted here. Patient usually tolerates these injections very well, and you just have to be subdermal, raise a bleb which just disappears in 4 to 5 hours, and then be careful that you don't go within the orbital rim. But not all crow's feet can be treated with Botox, so you should know this. As beginners, we are very excited to sort of go ahead and do Botox injections for all crow's feet, but sometimes it could be because of collagen degeneration, dermal sort of degradation, which causes static crow's feet as well, and these patients usually require filler injections or sometimes even a brow lift surgery. So this is something that you should be very careful about initially in your practice. Now the second most common and safe area to inject is the forehead. Now forehead, basically you know that it basically comprises of the frontalis muscle, which can have variable anatomy. So there could be a bifid frontalis, there could be a monofid frontalis, which you need to know about. In the forehead area, although it's the easiest injection area, you can have an interplay of the orbicularis and the frontalis muscle. So you should be very careful not to inadvertently inject in the orbicularis muscle, because then you will end up with a depressed eyebrow. So you should be at least 1 centimeter above the rim. You should also treat the lateral frontalis muscle, otherwise you will end up with a Spock phenomena. And you should avoid too much, you should not inject too much Botox, especially in the first sitting, because you will have frozen eyebrows and no movement at all, which looks very artificial. Now, as you see in this patient, this frontalis is a continuous frontalis, but sometimes there could be a pattern change where you could have two different frontalis muscles with a separate belly. Now, in this patient, we have injected these points. In males, you need to inject more as compared to the females. In females, the usual starting dose is around 10 to 15 units. In males, it is double. Sometimes you might have to add it up with a filler injection to hydrate the skin as well, because not all forehead lines, again, as I said, will just disappear with Botox. In females, the patterns, depending on the frontalis anatomy, will be different and can be sort of customized according to the patients. So as I said, in women, the usual starting dose would be around 10 to 15 units. In men, it would be around 20 to 30 units, because the muscle is bulkier than females. And then there is a technique called as microdroplet or watercolor Botox, where you dilute it 1:10. So if you're injecting 1 unit in 0.1, you inject 0.1 unit in 0.1 cc, which sort of gives a paintbrush effect on the whole forehead region and avoids a frozen look on the forehead region. Now coming to the last, but the most important and the most dynamic structure on the face in the periocular region is the eyebrow. This is one of the most difficult areas to inject. Even expert injectors sometimes need 1 or 2 sessions to balance the eyebrow in a patient, especially for the first time, because this is an interplay of muscles. You're playing around with the orbicularis, the procerus, the corrugators, and the depressors. So in this, you have to first examine the range of movement of the eyebrow. Look for eyebrow tattoos and microblading eyebrows, because they have sometimes falsely elevated eyebrows. It's not the normal position of the eyebrows, so the muscles can get a little mixed up. Avoid too low injections, because you don't want to end up with a ptosis, because it's not reversible. It takes 3 months to go away on its own. And always ask for a history of prior surgeries, because that also can change the anatomy, because brow lifts, you tend to sever the corrugator muscles as well. Usual injection points are in the lateral eyebrow, the lateral 3 points where you want an arched eyebrow. In the medial eyebrow, usually you target the procerus and the corrugator muscles to elevate the medial eyebrow. And depending on how strong the corrugator is, you might inject 1 or 2 points depending on where the tail extends, but try not to go lateral to the mid-pupillary line, otherwise you might end up with a Spock phenomena. These are usual standard points and the dosages followed as a convention in a patient if you're doing it for the first time. 4 units each in the belly of the corrugators, 4 units in the procerus, and around 2 to 3 units in the tail of the corrugator to get a nice subtle elevation of the eyebrows as seen here. Now this is a video showing how the eyebrows are injected. Now in the same patient, what we have done is we have so this is where the belly of the corrugator is injected. First you have to inject you can either choose to inject the corrugator or the procerus. So look how I am injecting. Usually you keep a thumb beneath the orbital rim, because when you keep a thumb beneath the orbital rim, the chances of diffusion in the LPS are less. Ask the patient to frown and see till where the tail of the corrugator extends. So again, I'm keeping a thumb beneath the orbital rim as a safeguard. The other finger can be used to tap to distract the pain from the injection. This is called as tapping or tactile anesthesia. And then last could be the procerus, where you pinch the procerus muscle in the center and then inject. Sometimes the depressor supercilii might also be hyperactive and would have to be targeted. But what especially women like is an arched eyebrow, and in this you have to target the tail of the eyebrow. In these patients, sometimes you have to go within the eyebrow hair to inject, so that you can get a subtle relaxation of the lateral part of the orbicularis, and the topmost crow's feet or the tail of the eyebrow can be used to get a subtle elevation, especially laterally in women. So in the eyebrow, it's very important, especially if you're targeting a female patient, to inject in the lateral eyebrow. Males will not like this, because males do not like arched eyebrows. Usually the eyebrows are straighter in males. After injecting the eyebrows, you also have to, before going there, usually a starting dose of around 20 units for women and 30 to 35 units in men is a good starting point for the eyebrow region. Now, sometimes, as I said, even in this region, you might have exaggerated glabular lines, which have to be dealt in a stepwise manner, where you can soften these lines by doing Botox, and then inject a little bit of filler in this region to sort of hydrate the skin and get a good result. So you might not get a desired result just by injecting Botox, but in this region, you have to be careful about injecting fillers, which Dr. Kasturi will be covering in her talk. Sometimes Botox can also be used to augment surgical results. You know, in the Indian subcontinent, sometimes patients are very conservative and would not want to go ahead with a brow lift surgery because it is more extensive. So after doing a blepharoplasty, you can offer them a little bit of Botox to lift the eyebrow, especially the lateral part in these points, and you can get a subtle elevation of the eyebrow, which makes the patient happy in the first 3 months, which also sort of relieves you from any other questions, why did the surgery not give me the desired results. So I always do a little bit of Botox in upper blepharoplasty patients, in my patients, especially in my practice, and they're usually very happy. And if the patient is happy in the first 3 months after your surgery, they're usually going to be happy and not trouble you. You can also adjust the tarsal platform show. Now, these are advanced indications which you should do after acquiring a little bit of practice, where you can sort of symmetrize the eyelid fold by injecting in the orbicularis and also in the frontalis muscle and adjusting the position of the eyebrow. And we all know that usually Botox is known to cause ptosis, but you can also treat a little bit of ptosis up to an extent of 1 millimeter by injecting Botox in the eyelid itself. For this, you have to be very close to the eyelash margin, inject around the proprioceptors of the eyelid, and you can get around 0.75 to 1 millimeter of elevation by relaxing the pretarsal orbicularis. Last but not the least, always when you inject, especially for the first time in a patient, you should always call them for a follow-up at 2 weeks, because the first time when you inject, even in the hands of experienced injectors, you might end up with a Spock phenomena where you have not targeted the lateral orbicularis and the frontalis muscle, and you need to sort of titrate the patient, and this can be very easily dealt with by injecting just 1 or 2 units in the lateral frontalis muscle to relax the unopposed force of the frontalis, and you get a good result. In the end, the aim of Botox injection should not be to have a uniform expression all throughout. You should sort of retain the expressions of the patient so that you get a relaxed effect and a good outcome for the patient and not a frozen face. Thank you.
Thank you, Adit. I'd like to request Dr. Kasturi to come in and speak on fillers. I don't think Madam needs any introduction, and she's the incoming and the current president of the APSOPRS as well. And Madam, over to you.
Thank you, Debraj, for having me in this course. And this course is running for more than a decade. And it's really wonderful to see and to hear all of my previous speakers. And also, every time I listen to them, and every time I feel that newer inputs are coming to all the different topics that Debraj has selected for us. So I'll be speaking on filler rejuvenation. So when I start about the rejuvenation, this is one of the most important. The filler is one of the best way to treat a aging face. And when I speak about the aging face, we know that the face is associated with hypertrophy of some of the soft tissue and also hypertrophy of the other parts of the face. So the best way to make a balance between the hypo and this hypertrophy changes of the aging face is by injecting dermal filler. For ophthalmologists, the most common indication basically for the periocular region, but being an ophthalmic plastic facial surgeon, the other indication is the rejuvenation of the face. And this is basically to lift, to volumize, and to rejuvenate. So one of the most common periocular indication for dermal filler is the tear trough deformity. And when I speak about the tear trough, it is basically a separation of the palpable part of the orbicularis from the orbital part of the orbicularis. But one should always know how to differentiate this part. This is what is basically a tear trough, and this is a correct tear trough. And this is what we call the nasojugal fold, which is the separation of the full of the orbicularis from the quadratus group of muscle. The second indication for the Indian especially is not only to correct the tear trough but also to correct the hyperpigmentation, and this is basically done by injecting the dermal filler along the periocular region. We do see hyperpigmentation very often, especially the dark circles in most of the Indian scenario, and this is how we inject the dermal filler into the tear trough, which really decreases the shadowing effect and also brings a good volume in the tear trough region by correcting the hyperpigmentation. So the second indication for us is after the tear trough deformity, it is the correction of the hyperpigmentation. And with the same filler, very often we see, especially in the early part, we see some amount of fat being bulged out here. And by injecting filler within this tear trough or the periocular region, you can conceal the fat, and these changes are seen immediately after the injection of the dermal filler. So this is how this is a third indication for us, where you not only correct the tear trough deformity or correct the hyperpigmentation, but also you correct the you conceal the periocular fat prolapse. It can be done by injecting with a needle or with a cannula. Needle is what all of us we started, but now I feel that a better tissue integration is always with a cannula. So all the indication now I have shifted to a cannula injection. So this is what you see, this is how, but it's very important that before injecting, you should be so careful that you need to aspirate, wait for some time, and if there's no positive aspiration, then only you should very slowly inject the product. So we usually consider the whole of the face as a unit, that is the upper unit, mid unit and the lower unit. So sometimes along with correcting the periocular region, we need to also touch the mid-face in order to give a more holistic treatment. So this is how I'm doing with a needle, and you'll see on the table, you'll see changes where you'll see not only the correction of the tear trough, but also the concealing of the fat. So the right side is being injected, and after the procedure, you can even see now, you can see some amount of fat at the prominent tear trough in the left side as compared to the right side, and this is what you see the results on the table, and these results are much better after a week or so. So this is another lady who has got a mild amount of palsy in the left side, and she is not liking the quality of her skin, and also she is not liking the bag and the tear trough. So this is how we do with the cannula, and on the table can you see the right side being injected. You can see the fat bag has decreased, the tear trough has decreased, and then the same procedure will be done on the left side, and you'll see a much better correction. So I feel that it not only corrects the tear trough, but it does multiple wonderful things around the periocular region with the same dermal filler. And this is how she was before. This is on the table after the procedure, and I can see that in the fourth important aspect is that it also converts this negative vector into a positive vector. So these are some of the patients where you can see before and after the procedure, even in the elderly patient, where this negative vector gets corrected into a positive vector. Another periocular indication is the correction of the V-frame deformity. What is this V-frame deformity? We know we have two prominent ligaments in the lower periocular region, and one is the orbitomalar ligament and other is the tear trough ligament. And this is how the V-frame deformity occurs, because we say that these are osteocutaneous ligament. That means they are coming from the arcus marginalis to the skin. But this osteocutaneous contact is only there medially and laterally, but centrally, if you look at here, this is osteoorbicularis. This is not in contact with the skin, and because of gravity, you see most of the tissue coming down, and this is what leads to a V-frame deformity in the elderly age group, and this is being best corrected with the injection dermal filler. So this is in the same way you can use a cannula, you can use a needle, and we see definite changes before and after the procedure following the dermal filler injection, and this gives a much rejuvenated look, as you can see here, before and after the procedure. So even when they do a animation, you can see that the unhealthy skin or the aging skin is not seen, and this is a lady where she has a very prominent V-frame deformity. So as I have already mentioned, we always correct the whole face as a unit. So when you touch the periocular region, it is essential that you also need to correct some amount of the mid face. So here I'm again using a cannula, and it is essential that you also put a finger in order to prevent any injury near the globe or to the globe itself. So this is how you, when you inject, and this is how you see the results before and after the procedure, and this is you find that it really corrects the V-frame deformity that I have been mentioning. And when she looks up also, normally the fat bulges. So this is a clear example how you can see that filler also conceals the bulging fat. And when she looks down, normally the fat should also go inside, but the fluid doesn't go. So you can see how it has filled up the space, and this is how the advantage of the dermal filler in the periocular region. So the other indication for us is the A-frame deformity. So what is this A-frame deformity? This A-frame deformity is being characterized by a very prominent superior sulcus deformity. The medial part of the orbital rim is becomes more prominent, and it gives a very deep medial hollowing. So this A-frame deformity can be corrected very well with the dermal filler, and this can be given pre-periosteal or a pre-septal. So the non-surgical way of correcting, which we see either in the elderly age group or patient having lipodystrophy because of the glaucoma medication. Those patients with the prostaglandin use, we see that the volume goes down. As you can see here, I'm using a image J, and you can see the volume has reduced much more. These are the patient who really works very good with dermal filler, and on the table you will change. The advantage of this dermal filler is the tissue integration is so good. Look at her pre and post, and you can see a very good filling up of this A-frame deformity with the dermal filler. And this is another lady, she is on prostaglandin, and you can see such prominent A-frame deformity. And then when I do a procedure for her, the same procedure, I prefer doing a pre-septal, because this is a much safer zone, and the tissue integration with the low G prime filler is much better. And you can see her, this is after the procedure, and when you look to her after few days, you can see she looks so very normal. So this is what we call the correction of the A-frame deformity. Another lady on prostaglandin news, this is not a very good picture, this is a WhatsApp picture that she has sent me, and also her sister is also having glaucoma, and following the dermal filler injection, you see a much better correction of this periocular region. Another indication for the periocular region is a deflated eyebrow, which Dr. Adit has shown so beautifully, which you can lift it with the filler, with the Botox, or it can be also done with the filler. And now I have converted most of my eyebrow lifting with that of the filler. So being an ophthalmic facial plastic surgeon, we also need to take care of the whole face and other structures in the face, and for that you all should know what is the concept of this CK1 point. This CK1 point is a point in the zygoma, and this is the most important point everyone should know, because it lies at the junction between the mid face and the upper face. Advantage of this point that it not only lifts the face, but also corrects the tear trough, and also helps in the lifting of the eyebrow. It can be done with a needle, it can be done with a cannula. I started with a needle, but now I have again shifted this point to a cannula, where I graze the periosteum while I do the procedure, and this really gives a good change. As you can see, the face is much lifted, much overlays following the injection procedure. Liquid rhinoplasty is something which has come in a very big way. Initially, Debraj also has been doing lots of surgical rhinoplasty, and now even the surgical rhinoplasty needs to be combined with liquid rhinoplasty for the finer modification, and this can be done with a high G prime filler, and we really get a very beautiful lift, as you can see here, before and after the procedure. Other indication being the nasolabial fold, which can be done with a needle, which can be done with a cannula, and really gives a wow effect. And these are some of the indications for us when we take care of the mid face and the lower face. The chin is a very important beauty point of a female. everyone should have an appropriate proportion between the upper, mid, and the lower face. And for this, we need to also do a rejuvenation of the chin in order to have a good proportion of the face, as you can see here before and after the procedure. Lip is something which has also come in a big way, and this is very nice procedure where it's not that the people wants a very big lip, but they needs a rejuvenated lip, which can be, and like here, when I was showing you, see, just after the injection, this is not being touched. You can see a little amount of lift and a little amount of volumization really gives a very beautiful look and much better rejuvenation to the face. This can be also done with a needle. It can be done with a cannula. Again, though I'm showing with a needle because it is much easier, but you also need to aspirate with. And Shilpa has already mentioned about the vascular supply of the lip, and you should be very careful while you do this procedure because you do not want to give them a bruise. So I prefer doing with both with cannula nowadays, but this is also a very good option where you can see a very good correction before and after the surgical procedure. So the same procedure can be done with the cannula where you just make one entry point, and this is a very important point because through this point I not only correct the lip, I correct the chin, I correct the DAO folding, I correct the NLF, and sometimes I go to the mid face, that is a CK4 point. So it is such a wonderful point that with a single entry, you can make a very beautiful correction, as you can see. And this is my last one where we talk about the skin boosters. Skin boosters is something because I feel the most, costly jewelry for a female is the skin. Because skin is something we take away with us when we die. It is not the gold and the diamond. So one should really take good care of the skin. Like this young girl, she wanted, just before her marriage, she wanted some radiance in the skin, and this is the skin booster, and you can see her before and after the procedure and see how beautiful she looks when she becomes a bride. It is not that you need to inject in a multiple point in the intradermal or deep dermal phase, but there are also a higher G prime skin boosters where the diffusion is so good that you just need to inject in 4 or 5 points. That is just a medial nasal point, the medial cheek point, the central lower cheek point, the pretragus, the jowl, and also you can give a point in the DAO. So this really gives a very good correction. And then lastly, these are some of the ophthalmic indication where we use it for the correction of the inophthalmos. As you can see, this patient, I think I should stop here. And lastly, I would like to mention, let me go to last slide. So the only important thing that though we get the immediate result, but the good result usually comes after 1 to 2 weeks. With this, I conclude, and thank you, Devraj, for having me in this course. And it's really wonderful to have all of you here. And also, though there are very few participants, delegates, but I'm sure all of you must be doing and are really interested in facial aesthetics. Thank you so much.
Thank you, Dr. Kasturi. Very enlightening presentation and all the new points. I now invite Dr. Devraj Shom to present his talk. As we all know, Dr. Devraj is the known name in cosmetology all over India and director of the aesthetics clinics in Bombay and multiple centers all over India. Welcome, Dr. Devraj.
Thank you, Shilpa. Thank you, everyone. Thanks for coming here early in the morning after the gala. And it's always nice to meet up all my fellow conspirators on this particular course. My name is Devraj Shom, and we practice mainly aesthetic medicine. Now, why are you sitting through this? I always use this in every ophthalmology course, and the reason for this is that if you look at aesthetics in ophthalmology, it's growing steadily. And if you look at this American Academy of Ophthalmology article, which got published just prior to the pandemic, this particular article actually said that by 2030, you will have aesthetics as one of the major contributors of revenue in eye hospitals. And that's very important. When I train multiple people, and I have trained plastic surgeons, dermatologists, general surgeons, ENT surgeons, max fac surgeons, however, the most difficult part for injections is actually the periocular area. And when you look at the periocular area, ophthalmologists have a disproportionate advantage because they are not scared of the eye, unlike other specialities. And that's why you should definitely look to get trained in aesthetics and use that appropriately. This is also important because majority of our oculoplastic training programs are only looking at things around the eyes, but unless and until you treat the face holistically, it doesn't really suffice. I mean, fractures or whichever disease you're treating does not necessarily end up getting restricted to only the periocular area. So you've got to treat other parts of the face as well. Now, this is one slide that I always bring up. And this is just to show you the power of incremental change. She's 30 years old, and you can probably form an opinion on her face, and you would probably rate her from 0 to 10, right? How do you think she looks from 0 to 10? Can't hear. 0 being the least, 10 being perfect. What do you think she looks like? 5, 6? Perhaps? Okay. What do you think? And she's aging, right? Every few years she's aging. What do you think? Okay. So the power of incremental change is immense. Any other part of the face, any other part of the body, what takes an inch to make a difference on the face is a couple of millimeters. And who understands millimeters better than ophthalmologists, right? I mean, ophthalmic surgery is all about precision, and that's why aesthetics is something which is very important for ophthalmic surgeons, in my opinion. I'm a diplomate of the American Board of Facial Cosmetic Surgeons, and in the US American Board actually has 30% or more people coming from an ophthalmology background, and that's the change that we through this course want to drive in parts of Asia as well. Now, when you look at faces, it's the OG curve. It's basically a S-shaped curve. But in general, the most important salient point is that your tissues are moving downwards and medially, brought about by descent, which is caused by the gravitational pull. So if downwards and medial movement of the face is actually your, what's causing aging, anti-aging would be anything which causes the face to move upwards and laterally. Why does the face age? There are multiple reasons. I don't think we need to go into the details, but in general, what is basically happening is that there are bony changes, there are skin changes, and there are mass-related changes, which are all causing the face to come down. In general, if you turned around and said that it's mother gravity which is pulling you closer to herself, that's really the reason for understanding how aging occurs. Now, this was the first paper on aging of the Indian face. It came from India, but there was no data available from all of South Asia, and we are genotypically similar in Bangladesh, in Pakistan, in Nepal, and multiple other countries. This particular paper which came out actually used a number of serial and sequential photographs to look at how Indian faces age. Now, obviously, aging is also a pattern, just like other diseases are. And unless you can actually identify how people age, how will you go ahead and practice anti-aging? Now look at her, try and understand the patterns which are occurring. She's 23, she's 37, and she's 71. Essentially, the most important thing is the shape of the face changes as you age, which is also one of the reasons that the face is becoming broader. And if you look at that, you understand that if you want to make faces, if you can make faces appear narrower, it will automatically look younger as people age. Look at what happens when the person goes to 76. Again, similar sort of faces, 20, 34, 45, and you can see the shape of the face is changing from an oval shape to a more roundish or even a squarish shape. And then you also look at the cervicomental angle, how that's getting completely changed and becoming obtuse as people age. If you're a male, you're also losing hair, which also makes the aging process progress further. Now, look at these sort of faces as well, right? So what did we discover? We discovered that the upper third of the face, because of the melanin in our skin, tends to age relatively well. It's really the mid face and the lower face which ages significantly, which is why also I make it a point to tell everyone that India is not really Botox and filler country. It's more of the lifting country because it's a sagging which is causing the neck as well as the jowls to become less defined. And so you have to look at lifting procedures. You have to look at procedures which reduce the volume of the face rather than increase the volume of the face. And that's very important when you come to South Asia. This is an interesting paper. I would request everyone to read this. It's by Lamperl. It talks about how the nasolabial folds age and what is the different classifications of the nasolabial fold severity. But for a face like this, which has just a line, it's just a valley, it's very simple. You can take some filler and you can put it just below the skin, and this is the sort of result you get immediately after. Obviously, the filler will absorb more water and it will become more set over a period of time, and you'll see better results over a period of time. But when you look at faces, you should always be looking at essentially dividing the face into the upper third, the middle third, and the lower third. And when you look at these sort of patients, upper third, middle third, lower third, it becomes very important to figure out where the problem really lies, because we are not only scientific consultants to our patients, we are also financial consultants to our patients. So in this particular patient, you can see the right eye is very different from the left eye. Even though the light reflex is right in the center, there is a inferior scleral show as well as a lateral arch to the lower eyelid, which is there on the right side, which is not there on the left. And especially when she smiles, you can see the difference between the two sides of the face becoming even more stark. This is apparent not only in the eyes, but all over the face, right from the top to the bottom. You can see that the left side of the face is the saggier side of the face. It's also the more contracted side of the face. Now, what do you do? I mean, in a patient like this, we would use my earlier speakers, Dr. Kasturi, Dr. Shilpa, Dr. Adit have done a wonderful job already, but basically a little bit of Botox here, just the way that some of them have shown, and a little bit of fillers like Dr. Kasturi has shown, and those are the sort of results you can create, right? So you can take the patient from here to here literally in the space of minutes. Now, you could also potentially on the right side do a lateral tarsal strip. But do you want to do a lateral tarsal strip? Do you want to perform surgery? Is it necessary to perform surgery? Those are the questions which need to be asked. Now, a patient like this, I'd request no pictures to be taken of patients, please. If you can please respect the privacy of patients, that will be appreciated. Thank you. So if you look at this particular patient, she's 32. She comes in at 32. She's got the right side of the left side of the face is higher. The entire left side, including the brow, appears to be higher. You also have left under eye fat bags, which are more prominent than the right side. You could do a blepharoplasty, but my question to you is at 32, do you want to do a blepharoplasty? And do you want to do a one-sided blepharoplasty? So you could treat these with fillers. My point is not that you have to use fillers in every case. My point is simply that if you have multiple tools in your armamentarium, you will be able to give the right sort of treatment to your patients. Neither bleph is correct nor fillers are correct. The right and the optimal use of both of this is correct in the appropriate patient. Now, which lasers do we use? These are our workhorse lasers, the carbon dioxide laser as well as the Q-switched ND-YAG. And learning to work with other specialties and collaborating with dermatologists is very important, because unless and until you collaborate with dermatologists, how will you treat a patient like this? For instance, this patient has undergone trichloroacetic acid peels, lactic peels, and 8 sessions of Q-switched ND-YAG laser. There was also this very interesting paper from my alma mater, from LV Prasad, which showed that if you have a patient undergoing LASIK surgery, patient actually post the LASIK is more unhappy than before the LASIK, because under eye dark circles tend to show up. And if you're not able to treat the under eye dark circles as a ophthalmologist, then what are you doing taking the glasses off in the first place? So that's why this is important, right? Now, when you look at some of these patients, you see eyelid bags. But again, like I said, the whole objective is to know that there are different ways to skin a cat. And the way to skin this particular cat was basically doing a little bit of fillers and a session of carbon dioxide laser to tighten the skin, which can give you results which are almost surgical-like. And knowing when to do what, like I said, is very important. So this patient, crepey skin, very deep and hollows all over, just like Dr. Kasturi had shown in the under eye area. So using Botox and fillers first, then doing a carbon dioxide laser, and then using the carbon dioxide laser to decrease the crepiness of the skin and tightening the skin, that's the combination therapy which would lead to better results. Now, you see a patient like this, and perception becomes your reality. I mean, at the end of the day, your face is the perception which is being presented to the world. She was 46, but she didn't come in to look young. She came in because she thought she looked worried, and she didn't want to look worried, she didn't want to look stressed, she didn't want to look fearful. All of those are perceptions which can be driven. You can actually do a little bit of Botox, a little bit of fillers, and transform the face completely. So she still probably looks 46, she looks younger, she looks more relaxed, she looks... So essentially what I say about our work is, we match your soul ages to your face age to your soul ages. So if you feel 16, well, not 16, but we can definitely make you look 25, even if you're 60. Some of the faces that you see will be very heavy faces. Now, that's a face from the Middle East, which is the Gulf countries. And when you see these faces from the Middle East, you will find that in addition to a valley, there is also a mountain which is there. And unless and until you can raise the mountain, you will not make any change to the valley. So the first thing is to actually use a high G prime filler, which is used laterally. The CK1 point becomes very important for that, or the L1 point as it used to be called earlier. And when you use a G prime filler, which is lateralizing the face and pulling the face up, you can actually get the mountain to move up. And once the mountain moves up, then you do a little bit of fillers in the, area of the nasolabial folds, and those are the sort of results you can create. Knowing how to do threads is also very important. Threads is something that we've been using for the past decade plus. I know there are certain countries in the world where people are worried about using threads, but believe me, we've used threads everywhere on the face, including in the nose. How do threads really work? Threads are basically like the stem of a rose, and essentially what they do is they lift the face from the inside. And as they lift the face from the inside, they actually engage the skin and lift it up, leading to very good results. These results last for 2 years plus. Now, in heavy faces like this, the threads become very important. In a face like this, if you were to do only fillers, you would actually add to the heaviness of the face. So lifting the face becomes important, not just filling the face. So what you do is you first lift the face with the use of threads. And after you've done that, then you layer the face with the fillers in the appropriate area. And then this patient is also post carbon dioxide laser, which is why you see the scabs on her face. What do you think of her? When you look at her and she's 48 years old, she probably looks very stern, right? She looks angry, but she's not really angry. She was a very pleasant lady, and how you look can make all the difference, right? So a little bit of high G prime, low G prime fillers, threads, etc., and that's the sort of results that you can create. And she looks more pleasant. And sometimes it's about making people look like a better version of themselves, not necessarily younger, not necessarily older, and more optimal version of the perception that they want to create. So I encourage everyone to think of people's faces as the gift wrapping around the gift, and you need to wrap the gift appropriately so the presentation to the world changes. Now, we also use a lot of medical devices, obviously, and if you use medical devices, then the Althera, which is the only US FDA approved device for non-surgical facelift, becomes very important. And the Althera is something which releases high intensity focused ultrasound. It's below the skin, causes collagen formation. One of the major reasons for aging is that collagen has stopped being formed in faces which are above the age of 30. And so Althera actually causes collagen formation, which improves the structure of the face and causes the face to be lifted up. How does it really work? This is the Althera being done. And essentially what you're doing is, it's just a device. It's a little painful when it's getting done, but it delivers ultrasound energy, causes the basement membrane of the face to actually deliver collagen, and takes things to the next level. That's another patient of ours undergoing the Althera. The Althera has pretty much transformed our practice. We were one of the first practices in India to invest in the Althera. And from 2017 to now, my facelifts or our facelifts have reduced by about 60% because the Althera is able to give very decent results. If you ask people how many people want to look young or better, probably all the hands in the audience will go up. But if you repeat the question and say how many want to undergo surgery to look better, then the number of people will be very low, because surgery, we understand as surgeons, could be unpredictable, and that's why non-surgical treatments work really well. these are almost surgery-like results, right? I mean, when you look at her, and this is actually the wife of the earlier Consul General of India from the United States, and when you look at her, you can see how her face has become much narrower, a concept that I explained in the first few slides, and you can also see how her jawline has become much more contoured, her double chin has completely gone. So for the lower face, really, there's no real substitute to the Althera. It works wonderfully well. Similar sort of a patient, and these are the results which are created. Look at how his entire facial shape changes. From a roundish face, how he becomes much more angular face, and that's he hasn't lost a pound, but he looks like he's lost quite a few kgs, and that's because the shape of the face has changed. Another device that we invested in very early was the venous freeze, and when you use the venous freeze, it's a quadrupolar RF with magnetic fields, and when you use the venous freeze, it causes tightening as well. So different technologies become very important in taking things to the next level. We also use the Sigma lift a lot. This is something we acquired in the recent past. This is fractionated HIFU. So it's the Althera minus the pain and minus the consumables as well. So it makes the treatment slightly cheaper and more bearable in terms of pain. The Sigma lift is a fantastic device, produces great results, and is something that we use a lot as well. One of the big advantages for all of us is that we are surgeons. Now, my talk tomorrow, we have an instruction course tomorrow on facial cosmetic surgery in the adjacent hall. My talk tomorrow is on the deep plane facelift. And the deep plane facelift is something that I've done possibly 2 dozens of in the last 6 to 8 months. And the reason that we do surgery is that not everything can be treated with fillers and with Botox and with threads, right? We are surgeons, so we need to know surgery. The mid-face lift is not the same as the deep plane facelift, but this is something that is even simpler. So essentially what you do is you go through the superior vestibular sulcus, you take 20 Prolene sutures through the malar fat pad, tunnel it above, blind, above the zygomatic arch and through a temporal incision behind the hairline, and then tie this particular suture onto the deep temporal fascia. The moment you do that, you see the left malar area looks higher than the right malar area. And when you are actually transmitting this, you can see how the pull gets transmitted. It's a small 45-minute procedure, and it lasts about 5 years plus. Very good results. And the big advantage of the deep plane facelift, the mid facelift over the deep plane facelift is the mid facelift has scars which are inside the mouth and behind the hairline. So it is relatively invisible scars that you get, and that's why it's a great treatment to do. How do you do this? And what happens when you do this? 68-year-old grandmom who came in wanting to look younger because her grandson wanted her to look younger. She came in from the US. And when we did an upper and a lower eyelid blepharoplasty, please don't take patient pictures. When we did upper and lower eyelid blepharoplasty with carbon dioxide laser and a mid-face lift, it transformed the face completely. Similar sort of a treatment done in a 70-year-old where we've used mid-face lift, blepharoplasty, and CO2 laser resurfacing to really make the eyes open up, but also make the person look a much younger version of themselves. This is a patient of ours who actually has been following up for the last 12 years. So the thing to remember about aesthetics patients are they develop faith in you. Once they develop faith in you, they want to stick with you for life. They are going to age next year more than this year. So you'll continue to treat them. So initially we did fillers, then we did threads, then we did the mid-face lift. And then after you did the mid-face lift, this is after the surgery, you can see how the face has got transformed. So essentially, if you have multiple tools in your armamentarium, you'll be able to treat people on a large continuum of problems. You're then not using only a hammer, and then everyone doesn't look like a nail. This is another surgery that we do a lot. It's basically a liposuction of the face. You're removing fat from the lower part of the face and transporting that to the higher part of the face. And then once you do that, the shape of the face changes. Please don't take pictures of patients. I request you to not do that. And the moment you take photographs, the moment you take the fat out from the lower part of the face and transport that to the upper part of the face completely changes. And the shape change in the face can transform all sorts of things. That's coming to my last few slides. 48-year-old who wanted her dignity back. This is not surgery. This is a combination of treatments using Botox, fillers, threads, Althera, lasers, etc. And you can see how the face shape completely changes. I mean, as you start using fillers, even 16, 20 syringes per patient does not seem too much if you know how to use it in the right places. People turn around and say that people on television look funny, but they don't look funny because of the fillers which have been injected. They look funny because of the way the fillers have been injected, and that's the most important thing. Masseter Botox has been spoken about by Shilpa, but you will be surprised at some of the results that masseter Botox can cause. It's a very simple 5-minute procedure. When you do that, look at the change in the shape of the face of the patient. You would think she's lost 10 pounds, but the essential fact is the shape of her face has changed. And if you look carefully, you can see how sequentially this goes. This was a paper that we've published now. And this is a paper which shows that if you do this 4 times, you can actually have results which last for 4 years plus. If results last 4 years plus in changing the facial shape and making it narrower with the help of Botox, why then do we need angle surgery of the face? Madam talked about non-surgical rhinoplasties, and I always say this, until 2018 I had not even gone ahead and done a single non-surgical rhinoplasty, but nowadays this is one of our most offered procedures. In fact, if my surgical rhinoplasties have been 1,000 plus over the last 10 to 12 years, this itself would have crossed 500 plus in the last 5-6 years itself. So the very common procedure now, and it makes a big difference, as you can see in some patients. You can also use threads for noses, which can lift the nose up. The objective is to lift the nose and to make it look narrower. When you do that, you can see how the entire nasofrontal angle as well as the shape of the nose changes. Even the nostrils change. The base of the nose is pulled up. Lots of differences. People say threads don't work. Ultimately, nothing works unless you know how to make it work. This is a beautiful lady. She's an actress. And when she smiles, you can see how the tip of the nose comes down. And look at how, just by doing fillers, threads, etc., you can change the shape of the nose. And if you can change the shape of the nose like this with no downtime, then why would you want to do surgery? So that's something that we need to know. We need to have different tools in our armamentarium. All in all, injecting fillers is not for everyone. You need to know when to use what, how to do treatments better, and transform faces. Ultimately, you can get surgery-like results, and these are surgery-like results. You can shape a hook nose, you can shape the deviated nasal septum, you can actually get the tip of the nose to move up and change the way the entire projection of the nose as well as the entire rotation of the tip occurs, and that can be done with the help of threads and fillers and so on and so forth. So that's it really. That's what I wanted to talk about. 2 more minutes to go. These are the papers which have been published from the aesthetic clinics over the last few years, and trying to contribute as much as we can to science. And we've got a wonderful team, and they help us look smarter than we actually are. So all in all, what I would like you to take back is that knowing when to fill, when to reduce, and when to lift makes all the difference. And ultimately, if you can treat people well, that is when you'll end up making a big difference to their lives. Thank you so much. I think we can open up for panel discussions. And, oh, sorry, I've got Aditi's talk as well. Start the next one. Our colleague Aditi could not be here. She had some exigencies and some things which needed to be handled with family. Aditi, this one's for you. Volume बढ़ाना पड़ेगा.
Apologies for not being there in person.
Volume. हाँ तो लगा दीजिए. Aditi is in practice in Chandigarh, and she's absolutely wonderful in everything that she does. चलो, चलेगा? नहीं आ रहा. Oh.
Thank you, Dr. Debraj and the team, for making me a part of this instruction course. I believe this has been running for quite many years, and it's a privilege to be a part of this. I'll be talking about how I am setting up my aesthetic practice and what you can learn from me. There are no relevant financial disclosures. So, as oculoplasty surgeons, why do we need to set up an aesthetic practice? The first slide is the reason number 1. If you see where I practice and I Google here Botox near B, the number of places that pop up within a 5 mile square radius are immense. There are more than 30 such places. So, this is the first reason that this is a treatment which is being in demand. A lot of people are offering it. A lot of it is done in the periocular rejuvenation, which I feel is our domain, and we should be at least aware about it and be skilled enough to know how to do it. How much of it we want to practice is something which we can eventually develop in our practice. The second reason is, as oculoplasty doctors, we do come across people seeking aesthetic rejuvenation of the periocular region, out of which surgical, of course, is one of the go to skill set that we have all acquired. But the list of non surgical procedures is immense, and there are so many options available that we need to be aware about them. How many of these we want to introduce in our practice is something, because they can complement our surgical results. They can help build up a clientele for the surgery. If somebody comes who doesn't want any downtime but wants to start off with something, we should be aware about these procedures. We should know how to perform them and offer them in a safe environment. The third reason is that botulinum toxin as well as hyaluronic acid fillers have had a deep rooted ophthalmology connection. In fact, the first published use of the toxin was for strabismus in the rhesus monkeys in 1973. And if you also look at the hyaluronic acid filler, it's derived from our ophthalmic viscoelastic devices, which was initially manufactured by the Cornell group for intraocular use during cataract surgery, and then later acquired by, which is one of the most popular AbbVie Juvederm products that we have in the market. So, coming to reason number 4, the common concerns will present to the ophthalmologist. They can be in the younger age after refractive surgery. Once the glasses are off, the periocular region comes into focus. At a later age, once cataract is done and the glasses are off, again, aging and sagging changes in this region will present to the ophthalmologist. And the patients may actually say that, doctor, now that my glasses are off and I see this bump beneath my eye or a dark circle or some kind of a tired looking eye, which was not there when I was using glasses before. So, is there something you can do about it? With the non surgical procedures, they are less invasive, there's less downtime, and they're more or less reversible, and they form a good repertoire of what all we can offer for the facial rejuvenation. So, this is the reason number 4, and how many of us are actually offering these treatments in our ophthalmology practices? To start offering them, the most essential step that we have is training. If we look at the curriculum for the ophthalmology, the dermatology, the plastic surgery, and the maxillofacial surgery, besides ophthalmology, all three do have a component of aesthetic medicine. While ophthalmology is focused mostly on the functional oculoplastics during the MS, MD, and even during the fellowships, dermatology really covers the minimally invasive skin treatments and energy based devices. And the plastic surgery MCH has a very well defined curriculum which includes both non invasive and invasive surgical procedures for facial aesthetics. The other way of gaining this skill would be to attend procedures and the trainings offered by the product manufacturers. And when we had done a recent survey of the oculoplasty people who had attended these trainings, a vast majority had already, and some were planning to attend these trainings to enhance their skills. So these are easily available and they should be regularly attended by all of us who are looking to include aesthetics in our practice. The next step is a clinical setup. We can choose to do all these procedures in the existing ophthalmology OPD with the slit lamp chair. Just need to add a few equipment that is required, basically a trolley with all the products that we need and a crash cart. Those are two essential requirements. We are all familiar with doing some procedures on the slit lamp chair, so including these, the important part is to ensure that your sterilization is intact. The second option to have a more aesthetic feel to the aesthetic procedures would be having a dedicated aesthetic practice room. So in my clinic, most of my procedures I do it in the slit lamp chair itself in the same room. Uh, I also have a flat bed which is my dry eye and dry eye workup room, which also has some devices which I have kept there. And when you want the patient to really recline flat, you can offer these treatments in such a setup as well. I do collaborate with a dermatologist, and these are some pictures from his basic procedure room setup. If we see there's a flat bed, we have some area designated with the equipment. We have some products, we have some things on display, and we do have a proper disposal technique. And the equipment that comes in is, of course, autoclaved and sterilized as per the requirement. And the storage unit is also there for all the products that we need to have. The new setup that I'm building, similar setup. I'll be having a slit lamp room with some procedures being done here. I'll be having a procedure room which is currently bare, but we're still in the phase of setting it up. What I've added is an aesthetic waiting room area with the good view, good sunlight, and a good facade, which while my patients are waiting for the procedure, they'll be able to at least feel more comfortable and not have the feel that they're sitting in a hospital. The procedures that we can start performing in the initial phase itself, we're all familiar with the functional Botox. We can add aesthetic Botox to it. Hyaluronic acid fillers, fat grafting, energy based devices, depending on what all we have. If we have radio frequency with us, or the intense pulse light, or the lasers, we can start with these. PRP and mesotherapy are also easy to use. If you have a centrifuge where you're making autologous serum eye drops, you might as well make PRP and do the injectable therapy for rejuvenation also. Thread lifts and other devices like high intensity focus ultrasound, body sculpting, all these do require some amount of investment and can be added on subsequently. Some procedures which should be strictly done in the OT include the hair transplant, the fat grafting, and of course invasive surgery like blepharoplasty. Ideally, you should also prefer to do the thread lifts in the OT in the initial phases. But whether you're doing a procedure in the operation theatre or the OPD setup, a crash cart should always be ready for any injectable procedure. The next step is collaboration. It helps with cross referrals, people referring the patients to you, people who are doing other aesthetic procedures but don't want to touch the periocular region will be sending. It's good to have a dermatologist on board. I personally have an in house dermatologist. Good to collaborate with estheticians and nearby salons also. You can put up your standees and advertisements, but this may be a little tricky and you need to navigate depending on what the socioeconomic status in your city of practice is. Once you've decided to have your aesthetic practice, besides your existing advertisement page for your opthal clinic, you need to have a dedicated page where you don't show more of pathology, where you actually show more of the aesthetic treatment outcomes and be regularly updating them. You need to have certain advertisements, soft advertisements, magazines, interviews, and you need to keep on showing reels and keeping engaging the people, the audience. You can show a little bit of the procedure being done to show how how the patient is comfortable, but be careful about the patient privacy. The next step would be keeping updated with trends. So it's good to be aware about what all is there in the market, what new things are coming. Do attend standardized webinars. A hands-on training and in-depth literature review of new products should always be done, but there is no need to follow blindly. And you must be aware of patients with body dysmorphia and unrealistic expectations who come in bringing standardized images of models and say, hey doctor, make me look like this. I really want to look like this. So those are certain things where you need to know where to be careful and where to say no. The rewards from these non-surgical procedures can be, of course, immediate client satisfaction, making a difference. The patient walked in with a concern which you treated and they walked out feeling much better about themselves. There are financial rewards as well. As a surgeon, we tend to feel that the blade versus the syringe debate, which is an internal dilemma. But I think once you get into the hang of it, you should just make them complementary to your surgeries and be able to excel at offering both kinds of procedures. With this, I'd like to thank my audience for the patient listening and thank you to the organizing chairperson for this instruction course for making me a part of it.
Thank you, Aditi. And we are being shown red flags saying that time's up. So have people from the next course come in. We could probably take a couple of questions before we end. Are there any questions? So either we were very clear or very unclear. Irrespective, thank you very much for being here first thing in the morning, and hope to be here at AIOS next year as well. Thank you.
Good morning, sir, ma'am. Can I ask one question to Kasturi, ma'am? I just wanted to know, about A and V pattern of, around the periocular region. When do we next repeat the fillers, ma'am? How long does it act?
I'm using no financial interest, but I'm using this Volbella product, which has got approximately 12.5 milligram per deciliter. So this product is basically, it stays for approximately 9 months. So, but nowadays what I was also talking to Dr. Adit, I'm using the PRP and making it semi-solid. It's just like a filler. So I have started using that because it becomes cheaper, but that needs to be repeated once in every 3 months. So if you use a hyaluronic acid filler, like that old lady, I think 1 year I have been following her and I have not given her the second dose. But the glaucoma patients I'm giving because they're still on prostaglandins. So the lipodystrophy keeps on going in. Glaucoma patients, yeah, I think I have repeated after 6 to 9 months.
Thank you, ma'am.
But they are very happy. They keep on coming. I don't even have to follow them up. All glaucoma patients are very happy because they're young patient, and when they see the sulcus getting so deep, and then they feel so rejuvenated, they themselves after 3 months only they'll say, "Madam, it's time for me. When should I come?"
Thank you, ma'am. And a question to Dr. Adit, about you're also working with thyroid eye disease, I just came across. So what about thyroid eyelid retraction? How do you treat with Botox or the steroid, or what do you prefer?
So that's a very good question. You know, around 5 years ago, we used to give Botox to most of our thyroid eye disease patients. But Botox in the LPS is so unpredictable because we all know that thyroid eye disease, the extent to which the LPS might get involved. Some patients might have a very bulky LPS, some patients might have a thin LPS, some patients might have more fibrosis, as to some patients might just have inflammation. So the dosage of Botox was very unpredictable in a different subset of patients. So we couldn't pinpoint, like 2 units of Botox might cause a correction of the retraction in some patients. In some patients, it might not cause anything. Some patients, it might end up with a ptosis. So right now, a lot of people across continents have shifted to injecting triamcinolone acetonide, which has a more predictable course, especially at least in the acute subset of patients. In the chronic subset of patients, I still believe after injecting triamcinolone, you need to perform a molarectomy or a LPS recession surgery. But Botox has a role, especially if you don't have your hands on triamcinolone, which is very easily accessible. I would begin with triamcinolone first, and then if you want to titrate the results further, then try Botox.
So I've been using tripod, and I repeat after 1 month, like 3 doses. If it works well with the
Yes.
first dose, it's okay. And after one month, I'm calling
Yes.
3 times. And also, this is basically when the patient is in the active phase.
Correct.
So but what is your doses? I have been using only 0.25 ml, that is 40 milligram per ml.
So 40. So that is a good dose to use because
I've been using very less, that is only 10 milligram per eyelid.
that is means you can. Some people are using 20 to 30 milligrams as well.
Yes.
Now 40 milligrams per ml is a good concentration because you get tricot in 2 concentrations, 10 milligram and 40. 40 milligrams is better to use per ml because in a smaller amount of dosage you are injecting, so the dosage is concentrated in the area where you want it to be. You don't want it to diffuse somewhere else. But you can even inject 20 to 30 milligrams at the same time, like 0.5 of 40 milligram per ml or even higher doses. But to begin with, I myself personally inject around 20 milligram per ml. You are injecting 10 milligram per ml. But tricot is also known to cause fat atrophy and sometimes even crystallization. So you should be careful about that aspect as well.
Better to use 5-FU and tricot 50-50%. I use 5-FU. I prefer 5-FU for the burnt out cases, and little activity I use steroid. I think 50-50, like 0.5 of 5-FU in 1 cc syringe with 0.5 of this one tricot. That means 20 milligram, and that comes in 7.5.
So
That comes in
5-FU is
25.
little painful. Do you also
Can we take
use
this
that?
offline? The next session is here. Can we please take this offline? Thank you once again for being here, and let's move on to the next session. Thank you so much. Sorry to hold you up.